Now, after finishing off the second section, we have almost covered that once we have made the history, done the examination, and we're done with the additional and other investigations, we're almost near to the diagnosis. But even during the examination, not every muscle could be tested. Sometimes we just do a overview of what group of muscle is involved. But sometimes neurophysiological studies are needed so that each and every muscle can be charted, and this is only possible by use of different mechanisms which have now evolved, like EEG and electromyography studies and NCS nerve conduction studies. In this section, we'll be going through what is electromyography, how it is used in diagnostic and evaluation of the patient, and what is intraoperative neurophysiological techniques. So what is electromyography? It's actually using electrodes which are being actually like a pin type electrodes being put into different muscles, so that they can once the electric current has been which actually acts like a nerve stimulant, which is delivered to this specific muscle, whether it contracts or not. That is actually it. Then there is a charting which is done, and that is really evaluated, so that we know that with this group of, instead of testing just the group of muscles, we exactly know whether this muscle is functioning properly or not, or whether there is associated weakness or not. It records electrical discharges of the motor units. As I just told you, there is insertion of a needle-like electrode, usually which gives us the stimulus form of electric current, and then there is a muscle contraction which helps multiple motor units are involved. Then what actually happens is there's increased number and amplitude potentials. This is that amplitude, frequency, and latency is measured, that how much it has contracted, what was the strength of the contraction, and how long it took the muscle to contract. And all these actually are deranged in different types of diseases. Sometimes if we are measuring the audiology is being done for sensory neural deafness, sometimes the white noise spectrum is given so that the nerve potentials can be measured, especially in the very rare cases of the muscles. Usually there may be, if the muscles are disordered, there may be fibrillation potentials, which are spikes without any current actually being delayed, and there may be a positive sharp waves, that muscle is contracting but not propagating the nerve potential properly. Then in case of neuropathy, if it is chronic or long-standing, there may result in a longer innervated units, that is increased latency of the muscles. Then specific nerve root syndromes can be used. For example, if a child had a history of fall resulting in a trauma leading to fracture shaft of humerus, eventually leading to radial nerve palsy, we need to rule it out whether exactly this is the only area where the problem is, and we can ask for them to do the electromyography of these muscles. So all those muscles who will be supplied by the radial nerve will show the pathology, but on the other hand, all those muscles who are being supplied by ulnar and median nerve will not show that kind of a pathology. So specific nerve root syndromes can be picked up. Other advantage is that comparison with other nerve root territories which can be used. For example, if we are measuring it on the right arm, we know our left arm is normal, so we can pick that up. So what is important is actually we have to, and the electromyographic studies help us to whether the problem lies at the central level. For example, there was some kind of a version of C5, C6 nerve roots that would present with a different set of symptoms, or was there a peripheral nerve injury? So that is actually EMG helps us to differentiate whether it was central, whether it's associated with weak arm or radial distribution of the paresthesias, it's a mononeuropathy, or it's a plexopathy, that is the whole of the brachial plexus will be just pulled off from its the area. Usually it could be, if it is associated with C5, C6 prolapse, then the symptoms would be of the C6 nerve root, and that usually affects would there will be paresthesias of the thumb and associated radial side weakness. If the median nerve roots and motor sensory potentials would be more affected as compared to others. An EMG of C6 innervated muscles, such especially with the wrist flexion and the thumb flexion, would be affected more as compared to the C7. But in case if it's a C5, C6, or if it's C4, C5, then probably the most effect would be on the C5 rather than C6. Then, what are the signs of neurophysiological neuropathic disorders? Then we have to elicit certain signs which actually determine whether this patient has really a neuropathic disorder and what kind of neuropathic disorders. Usually, associated signs include reduced motor or sensory potentials. This usually reflects a non-functioning or perhaps transacted nerves. There's a loss of sensory responses called as synapse reflects a disorder to the spinal foramen. For example, in case of brachial plexus injury, intact synapse in the hyposthetic limb suggest a disease proximal to the foramen. That, for example, the prolapse discs. Then there may be a conduction block. For example, intact distal motor response with a focal conduction block implies a neuropraxic recoverable injury. For example, there was tourniquet palsy. This usually results in neuropraxia. Probably there is something wrong at this time, but usually the nerve would regenerate and recover properly. There may be denervation changes on EMG more than 10 days after the injury to confirm the diagnosis, significant nerve damage and loss of motor nerve function. Any recruited volitational motor units and weak limb may be imply a potential of recovery. Usually, this actually helps us to determine whether where is the lesion in the peripheral nerves, whether it's central or it's peripheral, and whether it's gonna be there is any chance of recovery in these nerves or not. Because we have the only chance if we have to perform any kind of a nerve repair and neurotization, the window is probably from 3 months to 6 months. So if there is a chance of a recovery, we have to give it a time to recover. But if we know there is no chance of a recovery, we have to do something regarding this surgery. Otherwise, after 6 months, probably we will not be able to deal with the nerve. Then the only option left for us would be to do the muscle transfer. So because the motor end plates would be lost by that time. So again, as we are continuing with the EMGs, we have in case of lower limbs, we have to sometimes the patient presents with spinal cord compression and there is peripheral nerve impingement. So we have to EMGs helps us to determine whether it's a proximal root entrapment, for example, in case of a prolapse disc, or there is usually something else is wrong at the different level in the peripheral level. Usually, in case of prolapse disc, there is a preservation of sensory action potential involved limb. There is a lesion interruption as well, which is seen on EMGs. There may be normal SNAP and normal CMAP. Usually, intact sensory potential distinguishes root disease from peripheral nerve entrapment. For example, a sciatic nerve may result in a foot drop, but this sciatic nerve could be damaged at the lumbosacral plexus, or this could be during the surgery for any other pathology at the hip joint, or this could be due to posterior dislocation of the hip. This EMG would tell us whether the lesion is at the spinal root level, whether it's at the hip level, or some more distal to the where exactly is the lesion, where and is there any chance of recovery in this or not. So nowadays there's a lot of surgeries actually being performed with intraoperative neurophysiological monitoring techniques. And why we need neuromonitoring? For example, if a spine surgeon is actually performing a scoliosis surgery, and initially there was a problem with the vertebra that there was scoliotic curve, and he has fixed it. But the problem is post-operatively the curve is gone, the spinal vertebra is straight, but there is associated neurological injury. Wouldn't that be a disaster? So there are different actually techniques which can be evolved so that to avoid any intraoperative or iatrogenic neurological injury which may lead to nerve dysfunction. Usually, these are loosely termed as intraoperative neurophysiological techniques. These include spinal cord monitoring with neurophysiological test, that is called evoked potential test, that the patient is under the ketamine. Before surgery, is told everything what to do and what not to do, and when they will be asked to do this, for example, raise a leg or not. And in the almost in the certain phase of the disease, when this patient is under the influence of ketamine, is given a command to do this kind of thing. But now it has actually shifted to intraoperative neuromonitoring techniques, which are actually computer based and using electromyography electrodes basically to monitor whether there is action potential or not, which is being generated in the muscle. If this is not generated, then it's probably resulted in some kind of a neurological loss. Therefore, before doing the final fixation, they actually decrease the curve, so there's minimum stretch on nerves at that time. And which is actually done usually in combination with the techniques in EEG. There may be a minuscule response from the cortex. These are actually done by the neurosurgeon, especially they are doing this surgery at the level of the brain. There may is in case if we are doing surgery for the brachial plexus, we may like to be potential at C7 and L1 level. There may be associated Erb's palsy in which the potential in the brachial plexus, the Erb's point may be necessary, and we may see the latency of the response because to assess how much the muscle is actually affected. And the whole this process is actually done is to basically avoid accidental nerve injury. It may result in a delay in the latency. Other intraoperative techniques, as I just told you, that probably if a person is performing scoliosis surgery and during the correction of the curve, as we are doing scoliosis surgery, there may be a neurological stretch on the nerves. To avoid that kind of disastrous stress, which may eventually result in a kind of a nerve injury, neuromonitoring and intraoperative monitoring is actually utilized. Now there is no patient is the techniques have evolved in which intraoperative monitoring can be done through use of specific small pin electrodes like we are using EMG, and they can be later on documented in their tracings and amplitudes, frequency, latency can be documented on a paper. So we know, and during peroperatively it's very easy to do the neuro monitoring without actually waking the patient up or partially waking the patient up from anesthesia. So nerve or nerve root stimulation is done. Intraoperative EMG is performed in with needle in situ. If there is something wrong, then probably the curve is stretched back so that there's minimum stretch on the nerve, and cortical potential is actually made to assess whether the fixation is correct as well as not associated with any neurological injury. In this section, we have discussed the role of the electromyographic study, the EMGs, and we know that actually helps us whether what is the situation of the muscle, what is their action potential, how much latency and how much sharp waves are coming in the muscles, and what is actually the strength of the muscles. Similarly, it also helps us where exactly is the lesion, whether it's in the central area around the nerve cord compression, or where around the spine, where it is impinging on the nerves, or it is somewhere in the peripheral region. Thank you very much. Keep watching sqadia.com.